So I think my task was really to try to bring together a lot of the information, especially from the pathology standpoint, in terms of how we see and what we see in the clinic and how this helps us when we take care of our patients and also helps us in getting them better care. And so just to sort of start off with the most famous slide that I know of with the Gleason score, or Gleason grading, Dr. Gleason in the 60s, using 270 patients, hand drew the Gleason scoring, which to date we use and is, I think, the most important part of, at least as a urologist, when I'm talking to my patient and counseling them regarding what we need to do for that patient. Important information. I hope Dr. Klotz agrees with me because he just looked at me. So 50 years ago, if we take a couple of steps back as a urologist, there was really no screening. There was no digital rectal exam screening, so we didn't use digital rectal exams. The needle biopsy was in its just beginnings and wasn't really mainstream quite yet. Radical prostatectomy was very uncommon and at that time also very lethal. So it wasn't until the 1980s where that technique was perfected. Prostate specimens were also not very well examined or were not very well pathologically reviewed. And part of that is because there wasn't really much IHC techniques. But yet, Dr. Gleason was still able to really pinpoint and actually identify the various grading systems. 50 years later, because of what Dr. Gleason did, it is still, in my opinion, one of the most valuable prognostic factors, and especially for post-treatment to be able to help patients get further care if necessary, better surveillance programs, et cetera, et cetera. And then it is widely adopted within at least the urological oncology field as one of the most important factors in terms of when we're making our decision, or the treatment decision making with our patients. When we sit down and actually speak to them about what their options are, I think the Gleason score really drives us in terms of that. So I'm going to try to give you guys a little story here. So we'll start off with some clinical information. We'll go into the ISUP pathology consensus statements from 2005, 2014, and really try to tie in together how and where we are going with Gleason scoring in terms of urology and how we are going to use it to help our patients. So the important factors, in my opinion, from the urology standpoint, Gleason grade is one of the most important predictors, like I said a couple of minutes ago. It is included basically in all the steps that we use in terms of clinical decision making, and this was so important that we even made tables. So in my opinion, if you make a table using something, it's got to be important because it's in multiple publications. And so initially the Parton tables, and I like to point out the Parton tables because in my opinion, this kind of shows you the importance of Gleason scoring, because you can see that while PSA is an important tool, and we can have a whole discussion on PSA as a screening tool at some other point, what you can see is that the PSA doesn't necessarily correlate with what the Gleason score is. So low PSAs means you can still have a high Gleason score in your prostate, where high PSAs mean you can also have a low Gleason score in your prostate. And so I think that goes to show the value of what the Gleason score is. A couple of things I like to point out, which are risk stratification tables. We use risk stratification tables in the clinical decision making. They're very important. I mean, I think that there are a number of different risk stratification tables that we can come up with. There is one slide that I had with the 20 different definitions of what a low-risk prostate cancer is based on the different institutions and different parties that had defined them. But I think the one thing that I really want to point out is that when you look at intermediate risk or high-risk patients, we've been, for the longest time, grouping the Gleason 7s, the 3+4s, or the 4+3s, all under the same risk stratification, which is a intermediate risk patient, and then all the 8 through 10s as a high risk, and then we'll sort of get back to that a little later. And I think this is important because really, while we were grouping all the patients based on Gleason scores, PSA scores, and DREs into these very large groups, there is a difference in this, and we are just now really starting to get more data and identify that we may need to separate out these groups. A Gleason 3+4 may not be the same as a 4+3. And really this very nice manuscript from JCO about 10 years ago, so from the group down at Cornell, looked at 693 prostatectomy specimens, 119 biopsy specimens from the physician's health study and health professional follow-up part of the study. And really what they looked at was the 3+4 versus the 4+3 versus the 8s versus the 9 and 10s. And using the patients who had Gleason 3+4, using the patients who had Gleason 6 as their reference, you can see that a patient who has a 3+4 compared to a patient who has a 4+3 has a 3-time increased risk of having a prostate cancer mortality. And then the Gleason 8s goes up to 7, and then there's a significant difference between the 8s and the 9 and 10s from 7 to 19. And so really, while we are always thinking about these groups in terms of risk stratification together, this is really starting to show us that we need to start thinking about these differently. And so what have we learned? We've learned a lot about prostate cancer treatment, about prostate cancer outcomes in the last 30 or 40 years. And obviously Dr. Klotz, who's going to give us a great talk about active surveillance, I think, in my opinion, is one of the most important things that we've learned. And I think, and as well as focal therapy, which I think is the new wave and is also important. But I think that these types of treatments have really brought us back to the basics, where it's super important. It's very important to make sure that we really understand how these patients are graded, how their scores, what their risks are, and that we are actually doing it very accurately so we can offer them the best treatments possible. And Sarah Lewis just gave us a great talk on MRI, which it is part of my armamentarium for patients in terms of helping me make treatment decisions to guide those patients into treatment decisions. And then obviously the better morphological variants, the better immunohistochemistry, staining, the better markers that we have all also helped us to progress in how we treat our patients. So the practical application of the grading system, which I think are some of the more pathological issues, and please correct me if I'm wrong, because I don't want to say anything wrong here, but grading system is performed under low magnification. There's always been issues about what to call a 4 or what to call a 3, especially if you had occasionally small fused glands. That necessarily didn't upstage or change us, while that may have had a more aggressive feature to it. Small focuses of disorganized cells also did not change the earlier Gleason scores to the more later Gleason scores. And then the tertiary patterns were occasionally used, and if small areas were there, were not exactly observed or even documented to help us. And so in 2005, the 70 uropathologists gathered for a consensus statement to try to help us better grade and know the actual Gleason scoring for patients to help us guide them in treatment options. And just a couple of highlights. The Gleason score is the sum of the primary and the secondary. In needle scores, the definition includes any quantity of higher grade. So if there's a little bit there, we still have to say it, and we still have to document it, so we really know that there is still a higher grade Gleason score there. The Gleason 1+1 was outdated, which really, I guess we now identify as not necessarily cancer. Individual cells are not allowed in pattern 3s, which was just a caveat that I discussed in the slide before. Even if there is a little sort of disorganization in the biopsy specimen now, we will call that an upgrade or an upstage, as well as some other more detailed pathological changes, which I'm not going to get into because I really don't know about. So the tertiary pattern was also very important. So now tertiary pattern became more into the diagnosis of patients and allowing us to really have the tertiary pattern, even if there's a little of it there. Different cores showing different scores will now be, once again, reported and documented, so we really get the true breadth of what is in the patient's biopsy scores. And this is an interesting one, which I think is, and I'll show you some data later, about the percentage pattern of how much percentage of 4 or 5 is truly inside the specimen, whether it's the biopsy core or whether it's the actual prostatectomy. So after the 2005 consensus statement, the the modifications or the results of that meeting were that pattern 3 was previously the most common pattern, became less common than pattern 4. So now even these small amounts of dissociated cells that were in the biopsies that weren't called before are now being called, because we do know that that's a more aggressive treatment. Improvement in the inter-observer reproducibility, which is actually very important from one center to the other. And this way, as a tertiary referral center, we always get patients who've had biopsies on the outside. They come in with their slides. Dr. Haynes graciously reads them for us. And really, we really don't see too often, and maybe you can comment on that, but the differences are very minimal a lot of the time now. And the updates were based on the big problem, I think, was that the updates were based on personal institutional experiences, single centers, single pathologists, rather than actually proper studies. And then I'll get into that in a few seconds as well. So very important, the Gleason's grade grouping is, in my opinion, a great prognostic tool. The grading system from 2 to 10, but 6 is the lowest score used. I've always had a real hard time with this, especially when it comes to my patients. When you sit down with the patient and you tell them you have Gleason 6 out of 10 prostate cancer, it is very difficult, and it takes 15 minutes for me to really truly explain to them that it's the earliest cancer you can have. It's basically a 1. So don't let that fool you. But it does take convincing for patients to really truly help them understand that it is an early cancer, especially when you say it's out of a 10-based system. So a lot of patients will have some fears of getting less radical treatments if they hear Gleason 6 out of 10, and you definitely need to spend some time with them. The various Gleason scores have been grouped, which I think I've mentioned this before. So I think that this is something that we are really now in the forefront of changing and really understand a lot more. A Gleason 3 plus 4 is not the same as a 4 plus 3, and definitely an 8 is not the same as a 9 or a 10. The process of actually changing this really started with Dr. Epstein's group down at Johns Hopkins in 2013, where they looked at their database of 7,869 men who were treated by radical prostatectomy, and they looked at a multivariable model for biochemical recurrence and biochemical-free survival using a novel grading system. The grading system, which is called the prognostic Gleason grade grouping, is a 1 out of 5, which makes it a lot easier now, in my opinion, when I tell a patient that you have a PGG1 rather than a 6 out of 10, and that's really a Gleason 6. The separation of a Gleason 3 plus 4 versus a 4 plus 3, and the separation of a Gleason 8 from a Gleason 9 or a 10. So really having a 5 group system, which I think was very, very smart. Sorry for these poor Kaplan-Meier graphs here, but you can see that if we look at the progression-free survival or cancer-specific for these patients, as we break them down in groups, all the lines separate, all the curves separate very nicely, and you have Gleason 6 or PGG1 up here and 5 down here with very nice separations in the 8s, the 7s, and the 6s. And also, to me, the important and the nice part of these graphs is really the 4 plus 3s and the 4 plus 4s that actually, in long term, come together, showing you that really a 3 plus 4 is really different than a 4 plus 4. So, in conclusion, the authors of this study really came to the conclusion that while retaining the essence of Gleason's system, there is a need to change it. A change in its repertoire to more closely reflect tumor behavior rather than just keep on using the Gleason scoring. So using some of this information, but also some of the earlier information, there was another consensus meeting in 2014 this time. And again, while there are some more specific pathological changes, the big, I think, change in 2014 that the ISUP came with was the adoption of the 5-tier grading prognostic system that was brought up by the Hopkins group. And really, I think that we are, again, on our way for actually using this system as our gold standard. But just like anything that comes in science, you really want to be able to see some validation studies to show that this is actually true. And so that's exactly what Dr. Epstein set out to do. This is a very nice paper published last year in the European Urology, led by Dr. Epstein. This is a multi-institutional, so 5 international high-powered institutions with over 20,000 patients treated with radical prostatectomy. And then once again, they grouped all these patients into group 1, 2, 3, 4, and 5, and then did the Kaplan-Meier curve looking at recurrence-free survival. And once again, the groups came out very nicely in terms of recurrence-free survival, with the Gleason 6s being the most successful, and then group 3, which is the 4+3s, and group 4, which are the 4+4s, or 3+5s, or 5+3s, grouping together, and the 9s and 10s having the most significant or the worst recurrence-free survival. And really the end result of this manuscript was that the prostate cancer grading system reflects prognosis more accurately, being at the same time simpler to define and to use. Well, prostatectomies are not the only treatment for patients who have prostate cancer. And so the other more common or highly used treatment is radiation therapy. And so in the same manuscript, they took 5,500 patients from 2 highly respected institutions that treat patients with external beam radiation treating with radiation, so both external beam and brachytherapy. Once again, did the 5 grouping system in these patients and came up with exactly the same results. So whether you treat the patients with radical prostatectomy or treat the patients with radiation therapy in some combination or form, these 5 grouping systems really show you a very nice outcome-based curving, or Kaplan-Meier curves, separated very nicely as well. So the take-home message from this paper is really, again, that this new prostate cancer the new prostate cancer grading system is validated in over 25,000 patients, 20 for prostatectomy, 5,500 for radiation, and it's a simpler grading system to use with reproducibility. So in this era, where everything is based on genomics, or at least we're heading in that way, once again, Dr. Rubin and his group from Cornell said, well, this is actually a very interesting prognostic scoring system. Well, how does this actually reflect what we're seeing in terms of the genetic instability and in the instability of our outcomes? So they took 426 clinically localized prostate cancers from radical prostatectomies, and they actually did whole exome and whole genome sequencing on these specimens. And then very nicely here, and I'm sorry these aren't projecting very well, but what we can see here, this is a copy number graph. So these are all our chromosomes starting from 1, ending here. And then there are the prognostic grading system 1, 2, 3, 4, and 5. And you can very nicely see that as you're increasing in your prognostic scoring, that there is increased number of aberrations in terms of amplifications and deletions in the genes. And so this significant increase in the frequency of both amplifications and deletions as you're increasing the scoring system, which is very nicely shown here. Furthermore, that you can see that if you look at the grading 1, or score of 1 versus score of 5, that there is actually a difference in genetic instability, with PGG1 was haploid, and you go from 2 to 5, you increase your polyploidy of your DNA here, which again really shows that this scoring system is not only clinically relevant, where we can use it for outcome-based discussions after patients get treated, but genetically it's also showing the same. It's actually showing very nicely genomics that correlate with it. So, and I just had to put in this paper just because Michael Liebman was actually one of our residents who is a fellow with Dr. Cooperberg out at USC San Francisco. And then they actually used the capture data of over 10,000 patients with prostate cancer, and then also on univariate. And again, I'm really sorry that these aren't projecting, but these are basically 1 through 5, the PGG scoring systems. In univariate, there's a very nice correlation in terms of increased recurrence-free survival, as well as in multivariate, both being significant. And you can see these on this graphs, again, where they don't use the PGG 1, 2, 3, 4, 5, but actually the 3 plus 3, 3 plus 4, and so forth. You can see these are the purple line and the red line are the 9s and 10s, and then here the green and the darker yellow are the 7s. So you can see a really nice split again. So clearly, these are two very large patient studies using the prostate cancer, the prognostic Gleason grading score that actually show the validation and how very nicely it correlates with the patient outcomes and recurrence-free survival based on treatment, genomics, and so forth. So I really think that this, in my opinion, is enough data that this scoring system should be moved to the forefront while maintaining the actual integrity of the Gleason score, because that's what still this is based on. It's still based on the Gleason scoring. Just makes it a little bit more organized and a little bit more simpler to use, both from the patient's perspective and from the physician's perspective. And just a few more things about the Gleason score, and I brought this up a little earlier, showed you the one manuscript by Dr. Rubin and his group looking at 4 plus 3 and 3 plus 4. But really, in the 90s, this started in the 90s when the idea of what is the actual percentage, how much high-grade cancer do we have in our radical prostatectomy specimens and or in our prostate biopsy specimens, because that's important. If a patient who has just a little bit of 4 versus a patient who has a lot of 4 or some 5 or no 5 may make a big difference in terms of what the actual treatment should be for that patient and or what the outcome should be for that patient. And so this isn't a novel concept. It's been around for 20 or 30 years now. And so, but it's one of those things where, in my opinion, somebody said something, it was a good idea, but never really followed up until more recently, so in this group using the RSPC, the European Randomized Study for Screening of Prostate Cancer, so 281 patients from the Netherlands and Canada who actually underwent prostatectomy. So 281 of those patients were analyzed for the actual amount of high-grade cancer that was inside the actual specimen itself. And you can see here, so 0 to 1 millimeters, 0 to 3 millimeters, 3 to 10, greater than 10 millimeters of Gleason 4 prostate cancer in the specimens, and then looking at So this is the amount here, and then we're looking at the PSA levels here. And then actually looking at the outcomes on the patients on these Kaplan-Meier's. Again, these are 0 to 3, 3 to 10, actually showing that the more Gleason scoring that you have the higher percentage of Gleason 4 that you have in these specimens, the more likely you are to have a biochemical recurrence. And this was followed up more recently by a large study of 12,823 consecutively treated prostatectomy specimens and 2,971 preoperative biopsies from 2005 to 2014, analyzing the amount of Gleason 3, 4, and 5. And this is a busy graph here, this is actually looking at the the prognostic prostate cancer scoring, again, 1, 2, 3, 4, 5, similar, showing the similar results. And this is, I think, a more important graph where you actually are looking at the Gleason 3 plus 4s or the 4 plus 3s broken down by low. So it's less than 25% of Gleason 4 in the 3 plus 4s, or high, which is 25 to 50% of 4s in the 3 plus 4s. And then Gleason for the 4 plus 4s, low being 50 to 74%, and high being greater than 75%. And you can see a very nice separation in your Kaplan-Meier curves for biochemical recurrence based on the actual percentage of Gleason 4 that you have in the 3 plus 4s compared to the 6s and the 8, 9s, and 10s. While this is a very busy Kaplan-Meier, this actually breaks it down by minute percentages, but you can see that even by doing that, you get these very nice separations. So clearly, the amount of high-grade disease that you have in these tumors is important, and it does actually predict your outcome for those patients. So patients who have higher grade may need some adjuvant therapy, clinical trials, radiation if they got prostatectomy or something to that extent. So in conclusion, I think the Gleason grading system is one of the most important prognostic factors that we have as urologists. It's an important tool for allowing us to give our patients the best care possible. And then the novel grouping systems have clear advantages. They're more precise grading, for more precise grading stratification. They're simpler to use and probably a little bit more adaptive to your patients, with the lowest grade being 1. They highly are correlated to outcomes, and they're also correlated to genomic alterations, which I think is extremely important as a basic scientist at heart. So, thank you.